We're going to go ahead and get started. I know some people still filter in, but we'll go ahead and get started so we can, because I have a feeling we're going to have a lot of questions. So this is our session, the Making the Unbearable Bearable, CF Cost Care and Hacks from the CF Care team. As always, still shamelessly from anyone else that has a good plan. We have no disclaimers. Debbie Benitez, and I am Jana Yaley, and we are your moderators for this session. We have no relationships to disclose. This is our session agenda, just so you can kind of get a layout of what we're going to do. So Kyle Fisher is going to talk about what ICD codes for the common CF meds are. Then we're going to talk about documentation must-haves for CF meds from Hannah Fan. And then we're going to do some best practice for acquiring medical equipment with patients for CF with Lauren Willis. And then we're going to talk about some care assistance with the Compass program with Rebecca Williams. We'll be doing most of the speaking there. And then we're going to save all the questions until the end, but please feel free to go ahead through the app. If you have some questions, you can go ahead and send those, and then we'll have those, and we might be able to combine some of the questions together at the end. And then we'll just have a wrap up and closing. So some of our objectives for this session would be to differentiate some ICD-10 codes that you need to use for those medication approvals so you don't get those phone calls coming back at you saying, hey, you got to code it differently. Don't use the E84.9, use the E84.0. Summarize the best practice documentations for medication and durable medical equipment approval, and then identify some various services and resources and assistance programs that more and more patients are needing to use now. And then we'll have the question and answer time. So our first presenter is Kyle Fisher. He is a PharmD and is a clinical staff pharmacist at Keck Medicine at USC Specialty Pharmacy in Los Angeles, California. He completed both his Doctor of Pharmacy and PGY1 community-based pharmacy residency at the USC Alfred E. Mann School of Pharmacy and Pharmaceutical Sciences. Prior to starting his role in 2023, he was a lead pharmacist for the mass-scale vaccination sites throughout Los Angeles and has worked in various community-based pharmacy settings, providing medication therapy management and comprehensive medication reviews. In his current role, he provides specialty pharmacy services for patients with CF and interstitial lung disease for the Anton Yelkin Cystic Fibrosis Clinic and Center for the Advanced Lung Disease at Keck Medicine of USC. Please welcome Kyle.
Great, thank you for having me. So again, my name is Kyle, so I'm a staff pharmacist that works at USC. So I work directly within the clinic, seeing our adult cystic fibrosis patients, and then my other time is split between the specialty pharmacy, specifically working for specialty drugs, getting them approved and covered, and relaying that information to the patient. So we're going to be talking briefly about the ICD-10 codes, and then we're going to go into some just tips on how to get medications approved. Sorry, can you hear me now? All right. I have no disclosures to disclose. All right, so let's get into it. So ICD-10 codes, or the International Classifications of Diseases, was actually created by the World Health Organization. So what this does is it classifies diseases, related health problems, and abnormal findings, signs, symptoms, and injuries. And what this does is it allows for accurate tracking of diseases within the population across the United States. Because of this, it's become an integral part of the payment infrastructure for payers throughout the United States healthcare system. So it's broken down into different chapters. There's actually 22 chapters of which you can look up ICD-10 codes for certain diagnoses that might be addressed during visits. But today we're just going to be talking about the ones that are specific to patients with cystic fibrosis. That being Chapter 1, certain infectious and parasitic diseases. I'm sure you can think of a couple right off the bat. Chapter 4, endocrine, nutritional, and metabolic diseases. So we have diabetes within there, and cystic fibrosis itself is in there. We have diseases of the respiratory system, and then we have diseases of the digestive system. So we included a handout for you guys. It does have the ICD-10 codes and some drugs that we have success getting the medications covered for. You can look through that as I go through them. It's pretty much the same thing. So just getting into it, Chapter 1, certain infectious and parasitic diseases. We have some of our big infectious diseases here, of course, Pseudomonas being one of them. You could see that our inhaled medications are typically covered under that. We also have some of our mycobacterial infections, and it's important to note the indications for each. So RECase is indicated for Mycobacterium avium complex. RECase is not indicated by the FDA for other things. So just finding those caveats between the drugs will help you and lead to successful prior authorizations. Next, we have endocrine and nutritional and metabolic diseases. So type 1 diabetes is something that affects most of our patients. E10.65, this will allow for a lot of the insulins as well as testing supplies to be covered. There are restrictions based off of this ICD-10 code, based off the insurance plan, but we'll go into how to navigate that a little bit later. And then type 2 diabetes is treated differently than type 1 diabetes. So if you expand into the type 2 realm, you'll have different anti-diabetic agents that will be covered under the type 2 codes. And then bringing it back to one of the most important ones, so cystic fibrosis itself is a metabolic condition. So E84 is cystic fibrosis, and all of these other codes fall under that. Probably the one that most of you know is E84.0, so that's cystic fibrosis with pulmonary manifestations. You can get a lot of drugs covered under this ICD-10 code. Probably modulators is the biggest one that we do use. Inhaled medications like Pulmozyme can also go under there, enzymes as well, so again, depends on the insurance plan. Some of our other supportive medications can also be covered under E84.8, which is CF with other manifestations, where we have CFRD, CFLD, and any medication that might be matching the indications. And then we move on to diseases of the respiratory system. So outside of just cystic fibrosis, you can have other conditions of the respiratory system like asthma, COPD. These would all be included under Chapter 10. And most specialty medications do require ICD-10 codes to go under this. So like Dupixents, things like that, you're going to be want to be looking for like asthma codes or based off of the indication of the drug. And then finally, we have diseases of the digestive system. We know that GI irritation is a big problem that affects our patients, so you would be using these ICD-10 codes to get these medications approved. And I did speak earlier about how you can use E84.8 to get some of the supportive medications covered. This is true for patients with cystic fibrosis, but this is also these codes also apply to normal individuals who do not have cystic fibrosis, who might just have liver disease. You can also get drugs covered under that. And then finally, we have other ICD-10 codes that might be applicable to our patients as well, such as osteoporosis. And within our clinic, weight loss medications are becoming a new thing. So this would be our ICD-10 code to use GLPs. So these are the codes that we have, but what do we do with these codes? How do we make them work? So I just kind of wanted to talk to you about the life cycle of a prescription. So we start off at the provider's office where the doctor makes the diagnosis, and typically they're going to prescribe a medication and send it off to the pharmacy. What the pharmacy is going to do is transcribe that information on the prescription, submit it to the insurance, and the insurance is going to translate the information submitted to them and say yes or no. If we have yes, the pharmacy can dispense the medication. If we have a no, then this is going to be relayed back to the pharmacy, and it's also going to be relayed back to the provider's office. So it's really a continuum of getting a drug dispensed. And finally, at the end, we hope that the patient receives the medication. So these are just some general overviews and tips for how we're going to get the patient the medication. So at the provider's office, we're going to select the correct ICD-10 code. Does the diagnosis match the indication of the medication prescribed? And I'll go over this a little bit later. To further support your argument of why you want a medication, it's helpful if providers include in their supporting documentation chart notes for the diagnoses that were addressed at the visit and match that to the drug, as well as the indications for each medication selected. So why would we pick this drug over another drug? History of medications tried and failed. If a patient isn't doing well on a medication, then you need to switch the therapy. That's something great to include in your documentation. And finally, contraindications. If they have an allergy or an intolerance to one medication, we would we want to include that because this is another argument for you to submit to the insurance. Now, everyone kind of works on prior authorizations, but doctors' offices and the documentation is where that kind of starts. Moving on, so if you do have that sheet that we did make for you, I just wanted to kind of see if you found any issues here with this prescription that we sent to the pharmacy from the doctor's office. And if you want to raise your hand or... Okay, that's one. That's a great one. That's actually okay in pharmacy world, but specifically the diagnosis codes for the drug. Is there anything wrong there? Right. So just based, if we're looking, so I'm calling them J codes, but J code would be for other respiratory diseases. That doesn't fit Trikafta. Pulmozyme, again, other respiratory disease, it's under J. While there are other diseases that might need pulmozyme, this one's incorrect. And Toby Podhaler, I'll go over it on the next slide. So J44.9 is for COPD. Trikafta is not indicated for COPD. So if the pharmacy sends this to the insurance, they're just going to say no, because that's not the indication. Chronic sinusitis for pulmozyme, it's not indicated for that either. And then Toby Podhaler, we're in the right ballpark under the infectious agents, but Toby Podhaler is not indicated for a mycobacterial infection. So with this, this would be the correction. So Trikafta is nicely matched to E84.0, cystic fibrosis with pulmonary manifestations. Pulmozyme is also matched to that, and then Toby Podhaler is matched to Pseudomonas as a cause of disease for someone who has cystic fibrosis. And then just if you're looking at a pharmacist at this, the prescription's nice and filled out and clean, and all the information's there necessary. Some other key players, so the pharmacy, I already discussed this, so I think I can keep going, but the pharmacy is just going to take that information on the prescription and transcribe it to the insurance. The insurance is going to decode that and make a decision. And the decision will lead you to the next steps, either a prior authorization or an appeal. I included this because not all the insurances are the same. So certain insurances allow certain ICD-10 codes for certain drugs. And this is all based off of their formulary. And formulary medications are preferred by the health plan. And if they aren't preferred, then they typically need a PA. And when in doubt, always call the insurance. I know it takes some time to do that, but you can typically get all of your questions easily clarified. And they can even tell you which ICD-10 codes need to be required for the drug. So what are my tips and some things that we've learned as a team to getting prior authorizations approved? So I think I touched on this. So the drug package insert is like the first step you can go to. You can Google the drug package insert. It includes the FDA-approved indication for the drug. So if your diagnosis matches the FDA-approved indication for the drug, then that's one good compelling argument that your patient would be a candidate for this medication. Drug manufacturers. So drug manufacturers, they have MSLs, so medical science liaisons. They have reps. All of them are there to support you and trying to help the patient receive the medication. So utilize them. They're typically very helpful. And then most specialty medications have pre-written appeal letters. So as long as you know the diagnosis and that matches the appeal letter on their website, you can typically submit that. So save yourself some time. And then finally, appeals. So an appeal is a medication that you want to use that may or may not be FDA approved for an indication, but it's being denied by your insurance plan. So what are we going to do to combat that? We're going to find evidence from the literature to support the use of that medication for our specific patient. And then we're going to create a compelling argument driven by patients' specific characteristics and preferences with the combination of evidence. And this ties back into having good documentation from your provider's office. So if the doctor includes all of the reasons why the patient needs this drug and no other drug, then you can typically get the medication approved. And just as another aside, if you know the patient and you really think that they're going to benefit from this drug, include that, because if they're going to decompensate on another drug, then that's the reason you should be picking this drug. And then finally, utilize your pharmacists and other healthcare professionals. No one can do this alone, so we need to borrow information from other specialties. And just Really quickly, at our institution, we do have an umbrella effect. So we have direct patient care interactions. So getting to know the patient yourself really helps you support the patient. Something that we have at our institution is specialty and retail pharmacies within the institution, and we have EMR access. So all of that nice documentation that the doctors did for us, we can easily pull from the chart and submit to the insurance. And then finally, just a little plug for pharmacy. Collaboration with the pharmacy team alleviates burden on the care team, clarifies medication-related questions, and resolves medication-related issues. And this being because we're pretty much in the middle of the insurer, the patient, and the provider's office. So we're able to kind of be a middleman for all of that and act as a resource. And all of this improves patient-centered care. So I know we're doing questions at the end, but thank you for having me.
Thank you, Kyle. And just one thing I wanted to add on to Kyle's, though, because he was talking about documentation, just because I've had to do this within the last week, is they will also have you make an addendum sometimes on the clinic note to include whatever it is that they want included on that clinic note, even if it is from February, because they're just now getting to it. And so therefore, just to let you know that, just in case there's something missing, you can always addend a note. Our next speaker is Dr. Hannah Phan. She's a clinical associate professor and director of experimental education at the University of Michigan College of Pharmacy. In her 15 years plus experience in CF care, she established and developed the clinical pharmacist specialist role and the CFF clinical pharmacy technician team model at both the Pediatric CF Center at the University of Michigan and as well at her previous institution, the University of Arizona. Her research in medication education, adherence, use of medications in the school setting, and interprofessional care of children with chronic conditions has resulted in various peer-reviewed publications and presentations. Outside of clinic or the classroom, when we all have time, Dr. Phan enjoys amateur photography, baking, and spending time with her family and friends. Welcome, Hannah.
And thank you for the opportunity to come and share some experiences that we've had. So I'll be talking about documentation and the must-haves of documentation. And Kyle had alluded to all the different codes that we need to have in order for authorization of medications. But let's say you have a medication choice and your patient was prescribed this particular, like several different PPIs in a row. Finally found the one that works for them, but it's the one that insurance will not cover. How do you justify it? And so we'll kind of go over strategies on how to best approach the documentation and letter of medical necessity that you prepare. I have no disclosures, so I just want to make sure folks know that today's talk is not intended to like make you a guaranteed insurance for sure it's going to totally work all in one toolkit. I wish that was the case. And then the session will provide you guys ideas and resources and as well as tips in terms of what's patient-specific data you need to like have from the EMR to be able to justify medications when preparing a letter of medical necessity. So I'd like a little interaction in my session. So if you guys want to whip out your cell phones and scan the QR code, I have a question for you guys. What are the top 3 of those medications that I'm listing that you struggle with the most in terms of insurance coverage? So I listed like a whole slew of them. Hopefully it'll show me, because we couldn't do it on here, but I can see it on my phone, what you guys are voting for. Some folks saying Palmazyme, some inhaled antibiotics like Bethkis, some unusual antibiotics like colistin or things from an IV form, different inhalers like corticosteroid or long-acting beta agonists, modulators that are indicated by genotype but not by age, and then modulators with appropriate age but not having the appropriate genotype, CF multivitamins, pancreatic enzymes, a certain brand, PPIs, some motility meds. So the whole full gamut. And then some folks have trouble getting azithromycin through, and I'm sorry that happens to you. Okay, so looks like a lot of different meds are different problems. So some resources that I would definitely have handy in terms of if you have a lot of challenging prior authorizations where you are at a point where you need to draft a letter of medical necessity. Personnel is very important. We'll talk about that. A library of evidence in terms of like having a very good organized file system, and then a library of templates that can be developed over time. So personnel, I have to put in the plug. If you don't have a pharmacist and a technician, please get one. We each have different skill sets. So as pharmacists, we have the pharmacotherapeutics education and training, the clinical experience to be able to evaluate drug therapy accordingly, identify specific factors in which, what medication is the right for the patient and justify the need. And we also have very in-depth training in scientific literature evaluation. So we can throw a lot of literature at the insurance to make them tired and say yes. Pharmacy technician-wise, a lot of our technicians have excellent expertise in troubleshooting access concerns, whether it be training other technicians or calling local pharmacies with their technicians to make sure billing is done appropriately, prior authorization processes and logistics, and then understanding the nuances between different payers. And so having a good, solid backbone and team will help you with that. And said folks can also develop the templates and resources that I'm going to talk about today, and helping justify the what and the why for certain medications that you're trying to get authorized. So as far as library evidence, I would suggest, if you can, a filing system electronically that you have, whether it be OneDrive, Dropbox, Google Drive, whatever your health system allows you to have easy access to. So for example, I have a library of different articles based on like disease state, medication, and then like issue in terms of prior authorization. So I have a folder of like PPI articles in terms of like interchange of PPI or modulator off-label by age. So having those over time and collecting them as you see them in the literature and just putting them away for a rainy day is going to help you along the way. And as you're preparing letters of necessity over time, you'll learn to like recognize which articles need certain highlighting. I make it so easy for the insurance to see what I'm trying to tell them. Like, here's the article. Here is the highlighted section that applies to my patient. Please approve the medication. CF care guidelines. Believe it or not, some of the medications that you guys listed here are probably due to a lack of evidence that the insurance or payers have. I've been told by managed care organizations that, Pulmozyme's not approved for a certain age. I can't approve it. Well, infant guidelines say it's recommended if it's clinically indicated, which in this patient, they have been in the hospital 3 times in a year. So clinically indicated. Can't be used in a preschool guidelines. So I will highlight certain sections and send it to them. Because when I ask them, what literature are you basing this on, your decision on? I've been told a textbook before by someone when I've done like a peer-to-peer, a textbook that was probably published in 1970 something. And so I send them the updated guidelines, any updated key literature. There are key articles like cohort studies, case reports, especially for those off-label modulators, for those ones that you're trying to get modulator for a younger child who's not quite eligible yet, but very sick, and you're trying to get them stabilized. Highlighting like what applies to your patient. Like this patient has very similar characteristics, similar age, similar comorbidities, and it worked out for this child with these different outcomes. So please approve. And then citing said literature in a medical letter of medical necessity. Over time, you will hopefully have written various letters for medical necessity. Unfortunately, that's a thing that we all do. And so we keep our files, we just de-identify all of our letters as much as we can and keep them in our folders within our health system so that we can go back to them and like not totally reuse it, but have a template of like what sections we need to hit, the literature that it applies to, and then look for that specific data for our given patient and send that off to insurance. So for example, having templates for different letters and types and categories. So when you're trying to interchange your pancreatic enzyme brand, creating a letter template that has the different sections that you can like fill in for your given patient. If you need a trial off-label of a CFTR modulator, what sort of data do you need? So I have certain sections that I already outline and have ready. The need for Pulmozyme twice a day for more of your severe patients that can't otherwise have other choices for treatment at the time. Use for things off-label or that are unusual, like IV forms of inhaled antibiotics, specific inhaler, like a different type of ICS or a LABA, plus or minus LABA, and then building that library over time. So again, having that personnel think forefront and kind of thinking ahead and putting together those folders, and as they're developing those things, saving them for a rainy day, because you are going to end up using them again. And then you can adapt those templates for a new patient that you're trying to get something authorized for. So for letters of medical necessity, I'm going to go over like general structure, and then I'm going to show you one that I wrote for enforcing a PPI at a higher dose and a specific PPI. So depending on your resources and things, I would highly recommend, if you can, if you have a pharmacist, this is one area that a pharmacist could be very helpful. Obviously, it should be on institutional letterhead, but the general structure of the letter usually starts out with introducing the patient, the medical need that you're asking for. Then you summarize that patient's story. I like to use sob stories in my letters. This poor person has this, this, and this. They've been in the hospital this many times in this year of span. Outcomes such as this, lead to this. Like, you need to tell their story. It's basically storytelling. And then a summary of their treatment failure, if that's applicable. So what was tried before and what came of that? So they tried medications X, Y, Z, but unfortunately their outcomes were such and such and such. And so previous use of this showed the most promise for this patient and reduced their blah, blah, blah. And then killing them with literature. So any sort of citations that you can provide, not only citing the literature in the letter, but also giving them copies, because they love stacks of paper, to give them copies of the literature so they can't say that, well, we can't read the article, we don't know what it says. Well, here, let me give you a copy and highlight it for you in the sections that are pertinent. And so, again, mentioning and citing the literature, whether it be a cohort study, a case report, anything to support your argument for that given patient for a given medication. So, and that's where your library of evidence is really, really valuable over time. So keeping that up to date. So this is a case example of getting justified esomeprazole for a patient who the insurance wanted to do once a day dosing of 20. This patient needed twice a day dosing to be able to really control their symptoms. So at the very beginning, you'll notice I introduced the patient. I basically state I'm asking for prior authorization for this medication. Tell the story of that particular patient in terms of their condition, the comorbidity that I'm trying to control. And then citing, like, there's certain literature that are stating like a maximum dose is not sufficient. We're prescribing it as such. See, as described in the literature, see attached articles, and you'll see below, I gave them all the citations, and I also gave them copies of those articles as well. And then given the symptoms, blah, 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 now requires a change. I've already tried famotidine plus the dosing that you wanted. It's still not well controlled. Please consider based off of the references below. So this is a short version of a letter, but there have been letters that I've written, for example, off-label modulator medication use, where I have like paragraphs. I even create graphs of like lung function and BMI to show a picture of like, this patient's lung function is going down. Like, this is their lung function, this is their BMI, they've been hospitalized this many times in a year, they missed this many days of school, da-da-da-da-da. So it shows that impact of lack of approval for a given medication. And so I put together kind of like a table for you guys. It's part of the handout, but just general like things in terms of suggested phrases or patient-specific data that you might want to have ready as part of like writing a letter of medical necessity, or if you have ability to like change your noting templates and things. So for the pharmacists at our center at Michigan, we built into our note template, we see the patients a week ahead of our physician and do a full medical history assessment, changes to the medication therapy, check labs and all that stuff. All of our documentation, if we change something and we know that it's going to be off-label or an insurance issue, we actually write a paragraph that's in our note that the doc can actually copy paste and put in their note if the insurance company wants to see it on a physician's note. So it's very easy for our docs to be able to copy paste, use, including justification. So for example, like your inhaled antibiotic example on the third row, despite chronic use of blah, so inhaled tobramycin for Pseudomonas, this patient's name has experienced, and you can list all the different outcomes that have not gone well. To help reduce exacerbations resulting in hospital admissions, we request a trial of blah for 1 year. And so the data that you'd want to have, lung function in terms of trends and graphs are very helpful to show that. Pictures help. And then number of admissions of systemic antibiotic course in the last 12 months, number of admissions in the last 12 months, and then also citing the appropriate guidelines accordingly. For like things like inhaled corticosteroids with LABA, listing the trials for the different medications, despite chronic use of X, still results in this. If applicable, also note any issues with technique. So if you're trying to change from like an MDI to a certain type of inhaler, you need to also state like, despite trials with this particular dosage form, technique has not been achieved, or if there's developmental delay as part of diagnosis, you need to note that so that the insurance understands that it's not just based on age, it's based on ability to do the inhaler properly, and being able to manipulate the inhaler properly. Or if you're trying to get a patient to get approval for cyclosinide because you're trying to reduce steroid exposure, some data regarding adrenal suppression, like any cortisol levels that you have, what the implications of that may mean if they're being followed by endocrine. So, and then patient data to support that as well. As far as like different articles, the types of articles you're going to want are like cohort studies or case reports of people maybe failing the medication that they're forcing you to use, or the benefit of an alternate that you're trying to propose, including the outcomes. Similarly, when you're doing anything off-label with a modulator, I tend to give lung function trends if they have it, if they're old enough to have lung function, their weight and BMI trends, how often they've been in hospital, how often they've needed a systemic antibiotic, effects on quality of life, including missed school or things like that for the child, so that the story is full and they're not just seeing a patient's name and their date of birth, but they're seeing the patient themselves. And then, of course, the off-label case reports that you may see. So there's even ones for infants out right now. UCSF published a really nice paper for use in an infant, which I've used to get it approved for younger children. Proton pump inhibitors, similar kind of approach. Again, building that library and using phrasing as I have here with the data that goes with it. So symptoms, severity of disease, any GI notes that denote like, despite treatment with standard doses of blah, will recommend X, Y, Z. And then any other outcomes like ED visits, admissions, et cetera. So this kind of gives you guys like a little bit of a toolkit a little bit. And then I don't know if any of you guys have had to need to get approvals for biologic agents for asthma, for your CF patients, for example, for ABPA off-label, but using certain terminology and phrasing, as well as providing that, again, patient-specific data to justify like why this alternate is needed. We've tried everything else. This is the thing that works with the patient, as well as citing obvious guidelines. Sometimes the insurance aren't aware of certain guidelines, so making them aware. So take-home messages wise, various resources. We talked about like having the people and having the different libraries of both evidence as well as templates. The investment in those two libraries is well worth the time and effort. So if you have care team members that can put that time, effort, and build it over time, it will pay in folds over time, later and later, over and over again. So keeping those de-identified copies are very helpful. And when in doubt, always provide the payer data, more data, and of course, a lot of literature for them to keep them busy at night reading. And then we'll take question and answers at the end. Thank you very much.
All right, our next speaker is Lauren Willis, and she's going to tackle some of the DME equipment fun that we all have. Lauren Willis is a respiratory therapist with MS degree in health promotion and holds specialty credentials as a neonatal pediatric specialist, asthma educator, and a certified health education specialist. She has worked at Arkansas Children's Hospital for 28 years, assuming the role of a CF program coordinator in 2008. Throughout her career, Lauren has been involved in many CF Foundation activities, including co-development of the CF Coordinator Mentoring Program, QI Learning Programs, and the CF Newborn Screening Collaboratives. Her current interest in CF relates to new responsibilities within her state for the Newborn Screening Program. In her free time, she enjoys spending time relaxing on Lake Hamilton and Hot Springs, Arkansas with her family. Please welcome Lauren.
Hey, hi everybody. Welcome to Boston. I hope you're excited to be here as I am. I really am grateful to be a part of this session today and for you guys being here. So for my part of this session, I'm switching gears a little bit. I am not a pharmacist. So we're going to talk about acquiring the medical equipment in the home for people living with CF. I have no relationships to disclose. So just as background, I think we're all aware that people with CF use various types of respiratory equipment or medical equipment in the home to do their daily care. It could be to deliver medications, perform airway clearance, optimize their nutrition, or provide oxygen or ventilatory support. Therefore, it's important for us to understand the factors around how to obtain equipment in the home. So for my objectives, I would just like to review the process on how to obtain equipment in the home, review some documentation that you can use to support the medical need, discuss some barriers or challenges we may face, and some available resources. So I will say that I cannot include all home equipment in this talk today due to the time, so I'm focusing mostly on respiratory equipment. Our patients commonly use that, and selfishly, it's more in my wheelhouse than G-tubes. And that my experience is limited to pediatrics in the state of Arkansas. And as mentioned before, insurance criteria for services is going to vary a lot between adult and pediatric populations by state and by the payer. So let's start with process for obtaining equipment. The first step is the provider must order the equipment. And it's important, and as mentioned, just with a prescription, equipment or orders for DME equipment also require certain details to help facilitate insurance billing and insurance approval. So the order should specify the device or equipment that's being ordered, and including details on medication, dosages, and or settings as applicable. Should include the frequency that the patient will use the equipment, and note if it's brand medically necessary. We also want to include the duration that the patient should need the equipment. That could be like 6 months, 12 months, or 99 months would equal lifetime use. And ICD-10 codes, as Kyle mentioned, are not only relevant with your medications, but they're also relevant for home equipment. We want to be ensure we include a code that matches the equipment that's being ordered. We need to be sure the prescription has the provider name, signature date, and national provider identification number. And while most of us may use electronic orders, if anything is written, we want to be sure it's easily read. And having all this information can prevent an rejection for it being incomplete or a preliminary insurance denial, all which can cause delays of your patient getting the equipment. So the next step in the process, once you have the order, is where do we send it? So this is when we need to make a referral to a durable medical equipment company. And part of this process also is important to verify the patient's insurance benefits. We want to prevent any unnecessary out-of-pocket costs to the patient. So we want to be sure we're selecting a company that's in network and takes the patient's insurance, and that they're willing and able to provide the equipment that's being ordered. We also want to ensure patient meets insurance criteria. So you can, call the insurance yourself to verify these benefits, but a lot of times I let the DME do that legwork for me and let me know if there's any issues. Also, if the insurance does not mandate a company the patient must use, it's important to involve the patient and family in that selection process, as they may have a preference of a company if they have options. And then once you send the order, it's very important to follow up with the company and or the patient to ensure they actually received the prescription. As we've seen that before, they'll come to clinic and they still hadn't had the equipment, 3 months later. Along with sending in your order, you also want to include some supporting documents. Just as mentioned, is important with medications, you'll want to send a face sheet that contains the patient demographic and insurance information. We also need to include any clinic or hospital progress notes showing why the equipment was ordered and documenting the medical need. It's important to do this timely, as a lot of qualifying tests are required to be submitted within a 30-day period. We also want to indicate if other therapy has been tried or failed, And you can use flow sheets and test results to also help with certain qualifications, such as need for oxygen, such as desaturation events in a hospital, or abnormal studies that may show desaturation, such as a sleep study, a 6-minute walk test, or an overnight pulse ox study. You could also use blood gases. You could use cultures if you need to approve nebulizers for inhaled antibiotics, or CT results showing bronchiectasis to support need for airway clearance. The DME will also probably send you a form or a prior authorization form that has to be completed and returned before they will dispense the equipment to the home. And then, as mentioned, sometimes we need a letter of medical necessity if we don't have good documentation in the hospital or clinic notes, or if the insurance denies the initial claim. And then it's really important, as mentioned, to include a reference national practice guidelines showing that the equipment that's being ordered is following an evidence-based practice. So next, let's look at some equipment and barriers. Just want to mention briefly why it's really important to consider barriers is we know people with CF already have a very high burden of care. And if they can't get devices to do their treatments, then that's only going to heighten their burden. And studies also show that out-of-pocket costs correlate to poor adherence. If they don't have the correct equipment, it can also lead to ineffective therapy. And this also worsens health outcomes. So the first equipment I want to mention is aerosol compressors and nebulizer supplies. These can be obtained through different avenues, such as the DME, pharmacy, online, or directly from the manufacturer in some cases. But it's important to understand that there are many different types of compressors and nebulizers, and they are not all created equal. They can have different flow outputs and drive pressures and residual volumes and particle size delivery. Therefore, usually CF specialty medications have specific brands of equipment that are recommended to help optimize medication delivery. And if these brands are substituted, it can change the aerosol characteristics, which then impact lung deposition. So we want people with CF to have this type of equipment that can withstand the long, intense treatments they do that sometimes can be over 30 minutes of continuous nebulization time. We want them to have a good warranty versus a limited warranty, and the equipment should be reusable versus disposable to facilitate cleaning and disinfection so we don't have a contamination of that equipment. Sounds easy, right? Like, what's the problem? So we do have some barriers with this, and this was actually a survey was conducted by, this is a mouthful, the CF Foundation Nebulizer Compressor Accessibility Task Force Committee, and they identified barriers as reported by healthcare providers as well as patients and families. So one of the barriers was related to DMEs, and that there's not always a company locally that the patient could get their equipment through, or they didn't stock the recommended type of equipment, or they would automatically substitute equipment despite what was written on the prescription. The other problem with this is that DMEs may be unwilling to provide higher cost items due to the limited or set reimbursement rates by the payer. Now, as far as barriers to the actual nebulizer supplies, there can be limited to no coverage. An example is where Medicare will only cover like 1 cup per 6 months. And we know our patients need multiple cups to avoid mixing of medications and to help reduce the disinfection burden. But that may mean they have to pay out of pocket. As far as aerosol compressors, these all have different warranties. So some could be very short, or even if it's being replaced under warranty, there could be a time the patient's without a device, so they're not able to continue their treatments. Also, some insurance have long reimbursement intervals. For instance, they may only cover 1 compressor every 5 years. So if your patient has a device that goes out within 5 years, but it's out of warranty, then they have to pay for the replacement device. And the biggest complaint by far is device failures is that they're just not durable enough for the intense CF regimens that our patients must do. If you have patients that are on inhaled aztreonam, they will get a delivery device with the initial prescription, but you may find once the warranty wears off or is out of date on that equipment, it's hard to get replacement due to the limited distribution, and it's very expensive to replace. So what are some barriers to airway clearance equipment? Looking at PEP or oscillating PEP, it's very hard to find a supplier. There's currently no HCPC, which is a reimbursement code. We use a general revenue code at my center, but it's still not covered by a majority of insurers. As far as vest systems, there are different manufacturers, and it's important to be aware that insurance may have a brand preference. In my state, we had a local payer recently who only will cover a vest system that's comes from a in-state brick and mortar store. So this limits a lot of options that our patients face. Most insurance will also have a diagnosis-based coverage criteria. Thankfully, CF is on most insurers as a covered diagnosis, but they could have an age restriction. I have an insurer who will not cover vest under children less than 2 for some reason. We also can face coverage limits, such as insurers will only cover 1 per lifetime. So we run into this as an issue when patients maybe want a second device when they're older, like a portable device. And then more recently, unsure since manufacturers are no longer wanting to offer lifetime warranties on their product, how will this, be impacted by an insurance with this limitation? For IPV and OLE, again, there's no HCPCS codes. It's billed as a miscellaneous code. And in my experience, these are very difficult to get approved for home use. So what are some resources to help overcome these barriers? So this first resource is actually a resource to facilitate the ordering process to be sure that we've encapsulated all the required elements of the prescription. It's called Parachute Health. It's an online medical ordering platform that's HIPAA secure. Anybody have any experience with? Great. Questions go to her. No, I have some DME colleagues and other CF colleagues who've also talked about this, but I don't have a lot of personal experience. But it is looks like a neat platform where you can create your account. You can let me see. Will this work? Yeah. So you can select your order, select your device. And then it will walk you through all the prompts to be sure you've met all the qualifying questions and criteria. It will create a digital order that you can send electronically to your provider to sign, and then you can upload it to a number of suppliers, both locally and national chains. It also allows the option to track your order, so you can actually see when it's completed and delivered to the patient, and chat lifetime with or in real time with the supplier instead of doing calls back and forth. So what are some resources for the equipment barriers we talked about? Well, one option is for the clinic to stock and distribute the equipment. My clinic does this. We do charge supplies to the patient that we give out, but we're not convenient. We're the only center in my state. Some of our patients live hours away, and we're not a DME, so we don't deliver to the patient's house, and we do limited shipping. But we do, provide in-clinic supplies for patients. Another option would be to partner with a local DME, maybe a smaller mom and pop chain or store versus a national chain, and they would be willing to provide recommended supplies in return for business referrals. I had one colleague tell me that they worked with a local DME who actually would leave the supplies in the clinic for the team to dispense and the paperwork. And then the DME reps would just come regularly and pick up the paperwork for billing and restock the clinic. And that worked really well for that clinic. Other resources you may not be aware of include ability to get respiratory supplies through an enzyme reward company called Live to Thrive, where patients can earn points to redeem in their reward center. It has lots of nutritionals, but it also has a big variety of respiratory supplies if patients are eligible, that they could also get extra respiratory supplies through this program. The Healthwell Foundation has a CF treatment fund. Again, it's for patients who would meet eligibility criteria, and as funds are available, but they also can help provide access to different forms of respiratory equipment if you haven't ever had your patients explore that as an option. We encourage also to check with different state programs, as some states do have programs that will provide financial support to items not covered by insurance. And then if you have a family ed day, consider asking your vendors to bring some supplies to hand out to your families on those days. I'm not going to steal Compass's thunder. I know they're coming up, but I did want to mention they have a very comprehensive resource database. And mostly what I just wanted to point out was under this medical expenses tab, the second button here is related to medical devices and supplies. So you can actually search for medical equipment in their resource database for your area. And we'll let them direct all those questions. So in conclusion, best practice to order home equipment includes making sure the orders are complete with the required information, sending in your documentation timely for initial approval, and you also have to do it for your recertification and renewal, and to follow up to ensure the patient received what was ordered. Insurance coverage qualifications are going to vary by state, population, payer, and just for fun, they like to change it constantly. So as you know, the CF team has to be aware of any equipment access barriers that your patients are facing and try to stay up to date on all the available resources and programs. And I would just end by saying I think our biggest resource is each other. As the slide at the beginning said, was to learn and still shamelessly. We have a great community, so reach out on the web, the listservs, and find out if you're having problems, what others are doing. And also we have great support from the foundation at the national advocacy level. So definitely they can help with issues as well. So yep, I'll save my question.
All righty, and as Lauren mentioned, Compass is coming up. So our representative from Compass is Rebecca Williams. She is a senior program specialist with the Cystic Fibrosis Foundation. Prior to her current role, she served as a Compass case manager for 6 years. Seeing issues firsthand as a case manager, she is particularly interested in how social factors, healthcare cost, and insurance coverage challenges impact the CF community. She maintains a Master Certified Health Education Specialist certification from the National Commission for Health Education Counseling and a Community Resource Specialist certification from Inform USA. That's a lot to say. Yes, Rebecca lives in Delaware with her husband and 2-year-old daughter, where they enjoy going to the beach and exploring nature trails. Welcome, Rebecca.
All right. There we go. All right, thank you. I have no relationships to disclose. So who is Compass? So we're a part of the CF Foundation, and we are a team of trained CF patient advocates who are here to help you, your patients, and their caregivers with really anything, navigating insurance, financial issues, legal, and pretty much anything else that comes up. And our eligibility, we don't have strict eligibility other than helping people with CF or recently CRMS as well. But we don't have any insurance, income, or care center criteria. All of our services are free. And we can work directly with patients, directly with families and caregivers, and also directly with providers. And this includes anyone pre and post-transplant as well. And this is a little bit of a snapshot of some of the things we do and can help with. So helping people choose insurance plans, looking at plans side by side, educating them on what the differences are and what is going to best meet their needs. When they have insurance, verifying insurance coverage for something, troubleshooting any issues, and connecting with financial assistance and other support programs. Also helping them, connect them to legal help about protecting their rights, so any legal questions they have. And we also have a number of educational tools and resources, both for just educating people more about some of the the challenges with CF and if they wanted to tackle something on their own, but we're always there one-on-one support as well. So for more about the educational tools and resources, those are in the NACFC app, and then we also have a lot of information at our booth as well if you're interested in more on the tools and resources. So first, let's get this out of the way, what we don't do. So we don't provide any medical advice. We really leave that between you, the care team, and the person with CF to decide what's appropriate. We're there to help advocate with the insurance or otherwise once you all have decided on a treatment, but we don't make any recommendations. We also don't provide any direct financial assistance, so we connect to direct financial assistance, but Compass itself does not give out money. And we don't have mental health staff directly at CFF, so we don't provide any direct mental health counseling or legal advice. So we're not legal experts either. So we help connect to more appropriate resources for any questions. And we don't recommend specific for-profit businesses or services. So now that we got that out of the way, let's talk about how we can actually be helpful. So a big part is insurance options. So we can help people whether they have an employer plan or they kind of have an idea of what insurance options they have. We can help them look at those. Or if they have no idea and they need insurance, we can help see what they're eligible for, see what's appropriate, and really help them understand those plans, so give them some good options. We don't ever recommend a specific plan. It's typically a side-by-side comparison of 3 plans, showing them the differences, showing them what's covered, what's not covered, and more importantly, giving them an idea of what cost looks like with those plans, because coverage for something looks very different from what actually they're going to have to pay. So helping them really understand and make an educated choice with their insurance. And another big part of our job is insurance coverage issues. So this is certainly not all inclusive. These are just some of the most common we see. So anything related to unexpected medical bills, if people have more than one type of insurance, and they need help coordinating those benefits, who's going to pay first, who's going to pay secondary, switching pharmacies, whether they switched insurance and their new insurance has a different preferred pharmacy or pharmacies out of network and they need to find anything related to switching pharmacies, denials, network exceptions for providers who are out of network, and benefits verification. So they have something that is coming up, like a surgery or procedure or something, and they want to get an idea of, or they've been prescribed something, they want to get an idea of price. We can do a benefits verification to give them an idea of if it's covered, this is what will be needed, and this is what the cost could look like. And resource navigation. So when insurance is working correctly and they still need help with their out-of-pocket costs. So this slide is specifically for anything directly related to care. So we help connect them to local, state, or national resources for the things here. And a big part of our strategy is seeing what they already currently know about and are using and evaluating, are they using those resources to the maximum benefit? How can we move some things around so they can actually be using this grant, which would help with more, and then find a resource for that? So helping them make the most of resources that they already know about, or recommending, you're on this medication, you could probably use this manufacturer program for this, helping connect them to even more, perhaps beyond what they're asking for. And these are not necessarily directly related to CF care, but as you know, CF care is expensive, so people need help with other things as well too. So these are some of the most common, certainly not all inclusive here. If there is something that comes up in a clinic visit or a conversation with a patient and you're not sure if there's a resource, ask us, because we find things all the time that we are like, there's never going to be a resource for that. And then there is something. Or maybe we can't find something for that specifically, but something else comes up in that conversation that we can connect them to a resource that maybe they didn't think they needed help with, but would be helpful and would help kind of free up funds there. And legal. So we have the CF Legal Information Hotline, which helps us with anything related to Social Security questions, rights as far as employment and school, and any insurance rights questions. And then for anything other legal that doesn't fall into one of those categories, we refer to local bar associations or pro bono resources in their either county or usually state to help get them some answers to those questions. And so we have a Compass resource database. There's a QR code to, instead of using the website, and it doesn't require a login. This is for anyone in the CF community, so anyone can access this. And I will say, so we're constantly updating it with resources that we find and have vetted, and we keep that kind of updated as things close, open, criteria changes. So if you are using this and can't find what you're looking for, let us know, because we may know of something that just hasn't been put in this database yet, or we can research and find something. So this is for anyone to use. And yeah, as Lauren said, there's some guided searches there at the bottom to kind of direct you to. And so I wanted to share this, now that we've talked a little bit about how we can help. How does this work? How can we work best with care teams and people with CF to get positive outcomes here? So a big thing Compass can do is take some of that time burden away, really do some of the research of why isn't this being covered, look for resources, do a lot of the insurance calls, get put on hold, get hung up on, call back, kind of take some of that time burden away from care teams and person with CF. So really doing some research and gathering what's actually going on here, what's the problem, what's needed. And then if it is something where it's something that the care team would need to provide, like an updated prescription or a prior authorization or appeal or anything, like a resource might want a diagnosis verification, which the care team would provide. So really Compass can keep in touch with both person with CF and care center, let them know status updates, get care team involved when something needs to be submitted that comes from a doctor's office. And then hopefully that results in person successfully receiving whatever it is they need. And this is kind of an example. We can work with care teams and patients in many different ways. So we're very flexible with how this goes, as long as everybody's on board. And we have consent from the patient to work on this on their behalf or with them. Very flexible in how we can do this. And to further streamline that relationship, previously, our consent to be able to work on a person with CF's behalf or give updates to their care team was through either paper consent form that had to be mailed or faxed in, or a online form where they had to log in. They had to fill out this online form after already speaking to someone and then get help. So we've switched that to verbal consent as our primary method, which helps in eliminating that administrative burden for the family not to have one more thing to fill out, fax or mail in. It helps us be able to start working on issues sooner. So instead of getting a call, having to have them fill out consent and having to wait to start working on that until we have consent, we can get consent during that first intake and start working on the issue right away. And hopefully better collaborate with care teams too. So if we know the clinic is aware of the issue or they have referred the person to us, we can get that verbal authorization right there to be able to give care center updates, communicate with them. Sometimes they have more information about the situation, and then work with them to get the situation resolved for family. And so now I want to show you some specific case examples. So we talked kind of a little bit about what we do, how we can work with care teams, but wanted to show some specific examples of things that have been changed so that these aren't specific situations anymore to protect privacy, but give you an idea of how we can be involved and help. Ooh. Okay, so first one is the Altera nebulizer not being covered by Medicare. And we know HealthWell can cover that, but for some reason it was still getting a denial. So the case manager was able to reach out to HealthWell, figure out what was missing, why it wasn't going through, and turns out they needed a denial in order to cover it. So then the case manager was able to bring the care team in, help get that denial from Medicare with the pharmacy, and then HealthWell paid for the nebulizer. So that's one example. And then a little bit more involved example here. So the vest purchase versus rental. A lot of insurance companies want to cover vests as a rental, but for this particular person, it was going to be a longer rental period, so it would run into the next calendar year, the next deductible, and we were dealing with a very high deductible, high family deductible with a commercial employer plan. So the family wanted to pursue getting it purchased, having a one-time payment versus a rental where they would have payments for a certain amount of time, then deductible restarts, so they would have a much larger payment. So they were looking to avoid that with their huge family deductible. So the case manager set out on quite a journey to to find some answers here. Initially, and this was a DME company, so it was a vest that was not through a manufacturer. It came from a DME company. So initially, the DME company said, we only do rentals, we don't do purchase. So initially, they were looking for other DME companies that were in network that would do a purchase. We're running into the same sort of thing. No DME company was doing the purchase. They were all saying rentals. So they ended up going back to the primary, the first DME company, kind of escalating to someone who knew a little bit more there and determined that they could do a purchase, but they needed the prior authorization to indicate purchase instead of rental. So then case manager was able to work with care team to get a new updated prior authorization submitted. And then came the insurance company versus the third-party administrator. So insurance companies as well are more familiar with rentals. So initially they were saying, we're not going to issue a billing code for purchase. We only have rental codes. So the case manager was able to get the third-party administrator and insurance company on the phone, get them to talk to each other, get them to agree to release a code for purchase. And so ultimately this person was approved for a purchase instead of a monthly rental. So we're able to have a one-time payment that would not bleed into that next calendar and deductible year. Okay, and then this is so the Monarch, which is covered more now, but people still see high out-of-pocket costs with it. So they had a very large copay for the Monarch vest. They had an employer plan. So first, the case manager was able to confirm insurance had covered it correctly. Everything was okay there. It had been billed correctly, and it wasn't just run through the financial assistance, and insurance wasn't involved at all. Researched financial assistance was not finding initially any of our typical DME resources were open, so they were able to reach out to another resource, see if they would consider a request for DME. That resource said yes, so then the case manager was able to refer that person to apply for that grant. And then, so this is also an example of a case where the primary concern was this large copay for the Monarch, but in talking to this person with CF, they were on COBRA, so they were paying a really high COBRA premium too. So in that conversation and over the course of this case, the case manager was also able to connect them with a resource to help with the COBRA premium, so saving a little bit more money than they initially had asked for. and then a diabetic supplies copay issue. So this was a patient who was having copays for the Freestyle Libre sensors, even though they had secondary coverage through a state adult CF program. So they thought they should not have copays, weren't sure what was going on. And so the case manager was able to talk to the pharmacy, see what was going on their end, why the secondary wasn't being billed. Turns out the pharmacy was showing that the adult CF program is inactive. So then the next thing we do is call that Children with Special Healthcare Needs adult CF program, confirm that we have the right member ID, all the right information, and did something lapse? Is this coverage active? It was active. So so what we were able to do is escalate it at the pharmacy to get the payer manually added to their account, since their automatic verification system was showing inactive. So ultimately they were able to receive the sensors for no copay. And so a number of ways to contact us. So care teams can reach out directly to us to share things they're seeing, get resources, talk about challenging issues that they're seeing. Another option is to warm transfer patients to us. So if you want them to work directly with us, but are not sure that they'll call or want to make sure that they get connected and that we know that care team is involved, you can warm transfer them. So call with them on the line, get them connected, and then you can either stay on the line or drop off, and or email Compass and copy them. As long as you have their consent, they're okay with you emailing us and copying them. And that way we can then from that point reach out to them directly, because we do need some sort of initial contact from them as form of consent in order to contact them. So the warm transfer is kind of our compromise on how we can get that first contact, so then we can go directly and work with them, and then you have some assurance that that person has actually has reached out to us, and we're gonna work on it. And so I just want to point out, so we rely on care teams a lot to hear about issues. And even if it's not necessarily a trend yet, it's just one patient that's having a certain issue, it's really helpful for us to know about those things, because if we're seeing it in multiple centers or with one particular payer across the country, it can really help inform our policy work. So it's really helpful for us to hear about things from you all, because some of it then we can take to our policy team, let them know, and then they can go and advocate in some cases with those payers or to have criteria changed or whatever the case may be. So your feedback really helps policy and advocacy prioritize their work and their advocacy priorities. And then this is our contact information. So currently we have a phone number, our hours of operation Monday through Thursday, 9 a.m. to 7 p.m. Eastern time, and then Fridays, 9 a.m. to 5 p.m. Eastern time. We have an email, and we also have an online service request form, which at this time is only for people with CF and caregivers or legal guardians of that person with CF. So you can give this information to your patients directly to reach out, or one of the other warm transfer methods. And for some future plans for Compass. So we are always taking a look at how we can do better, especially with giving care teams updates on things we're working on for your patients. So expanding that follow-up to make sure you're getting that follow-through when you refer someone to us, and so that you know the outcome of what happened. And exploring some new communication tools, so other than our phone, email, and online form, exploring some things like texting to make it easier for us to communicate with patients.
Thank you very much.
Thank you, thank you.
This concludes the presentation, so we're going to be opening up the mic for questions and answers for our panel. We did receive 2 questions on the iPad, so I'll be addressing them now. This question is for the panel. Have you had good success getting continuous glucose monitors approved for people with CFRD using the diagnosis code E84.8?
Look at the code. I'd have to look at the codes, but typically continuous glucose monitors are indicated for people with type 1 diabetes and on insulin. So I would imagine if it's not being covered, you could probably make a good argument that someone with CFRD needs a continuous glucose monitor. Alternatively, you could try a different brand of CGM that might be covered by the insurer.
Okay, the second question is, does Compass provide anything that will highlight the help and assistance that Compass provides that can be given to the patient? In parentheses, something that would help explain what Compass can do or cannot do. Example, pamphlet or leaflet.
Yes, so we do have a number, I believe the Compass booth or the materials in the NACFC app, we have a number of materials in English and Spanish. We have a one-pager. I know, is there anything other than the one-pager? Brochures. And the one-pager, which is in English and Spanish. So yes.
I just want to say, can CF centers order those?
Yes, we also have a materials order form that is also in the app and at the booth where you can order those materials, and we have a number of little like pill cases and pens and different CF branded things, or on mycff.org.
Does anybody else have questions? I have a lot. First of all, great presentations by all of our speakers, but I did not know about the Parachute Health, so I'm going to be on that like when I get back. That's a really helpful resource. I don't know about you guys, but anything on the EMR does not e-scribe to any DME that I'm aware of, and we are all resorting to paper prescriptions. So this is wonderful if this can all be digital and can be tracked, because who has the time? Because I know our RT always says, who's got time to call the DME and find out if it ever got to the person? So I think that's really helpful. So I'm sure anyone who's used it, which we had one hand up that said yes, do you find it to be very useful and can track? Now, is it you? Yeah, so you mentioned by state, but I'm curious, does it also have you factor in their plan, right? So HMOs require auths and then potentially forces you to a specific DME. So how does that relate or translate for those people with managed care plans? Do you know? So like Medicare, like federally or Medicaid? No, this is great. Yeah.
I will say it doesn't integrate with your EMR. So you may, if you want like the digital order, you would have to, migrate it or upload it into your system. That's the only other thing, but it does have a nice.
That's wonderful. Spread the word.
Yeah.
Yeah, yeah. You still have to
Or
print.
route it, or, yeah.
Yeah. Don't open it. Yeah, that should be a disclaimer when we send the prescriptions to tell the patient to do that. I mean, it's like when you purchase any product at Target, right? It comes with the warranty card. I mean, no, right? It's
We have a form we give when we dispense that machine. And so we have a form we give that explains that this is a 5-year warranty. It's purchased by your insurance. If something happens within this 5 years, you'll call this number, you'll provide this serial number, register the device, and they'll overnight a new one, which minimizes the gap we were talking about of time delay that the patients would be without a machine. And some of them used to make you send it in, and then they would check it and see if it was going to be covered under the warranty. Did they drop it? Did something else happen to it? But yeah, so they've been a good company to work with as far as just an overnight return if it's covered under warranty.
So I was curious because I also heard you mention, this is perfect segue to the next question. You mentioned that Medicare only provides 1 cup every 6 months, but obviously we prescribe multiple meds and we need more than 1 cup. So how do you leverage HealthWell or Live to Thrive, as you pointed out, to get the other nebulizer cups? Or do you suggest that a person is purchasing them? Because I know that there's also a website that we've referred persons to called Just Nebulizers.
Yes.
And people can purchase them there. So I guess how are you utilizing these resources to get additional cups?
So definitely on the respiratory listservs, again, you'll see this is all over the place, kind of how people do it. Like at our center, we're pediatrics. We do dispense more than what is covered, and it's just kind of we eat it costs probably than that we have. We try to use the brands that are reusable that last 6 months. So it also depends on how many inhaled medications they're on. As far as Medicare, since I'm peds, I don't do a lot with that. That was information shared with adult colleagues about that. But we do, mention the HealthWell as an option or these other programs. But for the enzyme company, you cannot have state or federal insurance. It would be a private payer covered only that could use that rewards program. So that kind of limits my population a lot because in Arkansas, the majority of our population has a state payer. But it is available. So just mentioning that it is a resource for someone. And then, but I believe, there's also, like you mentioned, websites that patients can purchase extra equipment to have, but it's an out-of-pocket cost for that. I was going to mention too, I forgot in my presentation, sorry, that there is a resource document that I created that had the information in the presentation, but additional information about other products we didn't, or equipment we didn't get to today, and websites or other resources for places patients could get equipment. So is that downloadable through the app? And I also have some copies here, but it does talk about other options like the online websites that patients could purchase directly from, but it is an out-of-pocket cost.
No, they've actually, yeah, they've done away with side stream nebulizers. Genentech has, so those are gone. But with the online sites too, I mean, patients can, with commercial insurance, they can use their HSA funds to purchase those. And then sometimes some of the sites, just nebulizers, Nebology, Amazon even, and because you can get everything on Amazon. And I just always tell patients they're going to use their HSA account, have a script just in case they get audited. And so therefore they have it. But then also sometimes they just kind of have to watch, because there'll be deals where you can get 5 nebulizers for a certain price, and it's a little bit cheaper than buying them individually. So therefore you just kind of have to monitor it. But sometimes they will have deals.
Yeah, and the other thing I may mention, if they're on an inhaled antibiotic, there is a brand that does package their inhaled tobramycin with a neb cup. So whenever the patients get a fill, that monthly fill, they will get a new nebulizer cup with that brand. If it's one that would, I'm not marketing anybody, but it's
Some of
one
them.
that your patient can use, they do come packaged with a neb cup. So that also helps with that.
Also, I heard, I want to ask a question, because I heard about the Health Well. I guess, how is this different? So we know we have Health Well for medications, and we know we have Health Well for the nutrition supplements. Is this Health Well fund for DMEs under the nutrition one? Or
the
CF treatment.
right, so if many people are using it for modulators, this might impact the availability for DME, right?
Yes, so there's only so much money if you're approved. It's so much a year. I believe it was 15,000 up to so much money per year. And if you go on the Healthwell CF Treatment Fund website, it will share the products that they can use that money toward, which is different medications and also DME, but it's all from that same pot of money. So if you need that 15,000 for something else.
So I also heard this because I'm on the Access Steering Committee, and I heard, I don't know what it was at Compass, about how considering Compass to talk to the CF person or family when it comes to the first time that they will need assistance for Vertex. Specifically because there are ways to utilize some of the resources more in a more orchestrated fashion, so as not to exhaust Health Well right away. So I think this is important for lots of centers. I did not know this. This is something that I learned more recently. And so we need to be more thoughtful about when we are asking someone, just use your Health Well. That shouldn't be our first answer. First answer should be, let's call Compass. Let's figure out how we're going to use your resources, because this thing that we're talking about with respect to neb cups and compressors, which we're actually seeing more and more of an issue getting coverage and more out-of-pocket expenses laying on the person and families who can't afford, then we need to think about other ways that we're utilizing these resources wisely. So perhaps you should also consider that, because I learned this and realized that we had a few people that could have used their resources in other ways. So please consider that as another avenue. When you don't know if there is a resource, just call Compass. Literally, we need to wear T-shirts in clinic that says, we know someone that can help you and might potentially have an answer for you. Because as you can see, all of the examples that she shared aren't everything. I know there are other things that they do. I did not know they helped with pregnancy and adoption. That has never crossed my mind until I saw that slide. And I know in the adult space where I work, we get lots of questions about, are there resources to help if we want to do like fertility? And I don't know. But so really the answer I should be giving is, let's call Compass. Let's call Compass, because what if there is? So you'd rather have them at Compass trying to help figure that out than you spending the time, which clearly we don't, and all the other things that we have to do for our CF people at clinic can now be shared with our extended arm, which I always like to tell people. They're the extension of what we can do because we don't have potentially all the information, but they might. So always consider that as an option. And then I do have a question about one other thing, which is what happens when people, because right now we're seeing, and again, I'm only speaking about my experience, is we're seeing lots of people on Medicaid moving into managed Medicaid programs. I know that this is likely going to happen in the future for most states. So are there ways that you can help these people who get placed into the managed programs, and these managed programs won't, well, I should say, forces them to see a pulmonologist literally within the HMO first, and then get redirected, which creates a gigantic gap between when they last were seen, when they were swapped over to the new managed plan, see the pulmonologist, which, by the way, they can't see the pulmonologist in the in-network until they see their PCP. So it's literally 4 steps before they come back to the CF center. Now they need refills. Now they've gotten sick because it lands right in the middle of the flu season, right? January is around that respiratory viral season. So what can you do to help, and what information do you share with them?
So sometimes we look for, with that state, if there's any sort of exception to, because this person has a chronic condition or a certain need, can they be exempt from an MCO and do fee-for-service Medicaid? Which I don't know how frequent I mean, it's definitely happened because it comes up with transplant too. Like there will be no in-network transplant center, and we've been able to like get people out of, or the MCO is not in network for transplant or something. And we've been able to get them out of the MCO and back into the fee-for-service where there's a broader network and there's more options. So them having CF and probably other chronic conditions too, that's a hack we've found to see if the state will budge there, because they're going to potentially have unmet needs and therapy gaps by being in that MCO. So that's one area that we've identified that is an option. Mm-hmm. Yeah, there are definitely some loopholes there too. Like you can change once every quarter or like in the first 30 or 90 days. Yeah. And that happens a lot with people who are dual eligible too. So there's a lot more flexibility when it's Medicare, Medicaid, or just Medicaid to be able to change outside of just open enrollment. Yeah. Good call.
Yeah, I think those are great ideas, although we've also now been running into exemptions being denied. So I think that's an issue. And I think because our state, because I'm from California, it's traditionally very large. And so our managed Medi-Cal is forced by the county where they live. So it's not like you can switch, right? So that, but because if they could switch, that would be the greatest option. But sometimes that's not an option. And exemption, my understanding is some states are moving away from allowing the exemption. You have to meet certain criteria. And I think that's my biggest argument is, well, what is your criteria to exempt? Because if we could understand that better, then we can actually help to support and reduce the gaps. But I think that's something that I know I brought up to the policy group. So if you are experiencing anything like that, very similar to what we're seeing in California, I would ask that you bring that up at your advocacy groups within your state and or to the CFF, because we're stronger together. If we are all seeing this happening within your state, then we can advocate as a group for everyone. So thank you.
I had a question for the pharmacy group. In our state, it's been interesting this year. We're seeing several commercial payers who, and I forget the term for it, but they've made modulators an exception to their plans. Like they will not cover them at all. And they force patients to try to find alternate coverage for, they remove specialty drugs in general from their plans. And they require patients to find alternate funding for that, like through some of these PBMs. Have y'all heard of that? Or it's a, what is that called? It's not a high deductible plan, but they actually exclude them. And it takes a lot of work to get it approved.
Alternate funding programs,
Maybe that's what the term,
like self-funded plans are doing.
no, they're commercial plans.
Oh,
But
like
they're,
plan excluded,
they just exclude all specialty meds, yeah. Yeah. So you know,
Compass has a session tomorrow at what time? 12:30 on navigating insurance challenges that will cover this.
Call Compass. So, are those patients also dual covered by state Medicaid as a secondary plan? Because I've seen that with some of our patients where they have a commercial, but they have secondary, like children's special health, which is their state funded. And so they cut the specialty off of that, hoping that state Medicaid will cover, which luckily, thank goodness, our state does that. But
our pharmacist has had to write letters and show that there's nowhere else, like Vertex, the manufacturer's not going to pay if insurance doesn't pay.
so like
There's
commercial
no,
only insurance, right?
Yeah.
No other.
but they've totally excluded. It's a PPO, yeah, it's a, yeah. Yeah. So it's just been a handful of private payers, but they've just excluded all specialty medications.
So, I don't know if this is available in your state. So some states will have availability to purchase secondary insurance through the state at a higher.
Yeah, you have
per
to
diem.
pay like a secondary.
Yeah, so that might, I know it's not ideal, but that might be an option if that's available in the state for those patients who have commercial and have that gap in terms of like modulator coverage because of those changes.
Yeah.
We've had to actually have a few of our patients, we're telling them like, I know you're going on a modulator, please get on the secondary insurance. You're gonna have to pay out of pocket, but it's way less than what you're gonna pay out of pocket for
A modulator.
modulator. Yeah.
Yeah, sharks.
Yeah.
Just deny it, like, or approve it, and then say, like, okay, you owe $10,000 now, and she won't be able to afford it, and Vertex can kick in for assistance. And finally, when I kind of wrote a letter of medical necessity and just put it in there, like, just approve it, they can't afford it, like, just do that for me. They're like, okay, I do that, and Vertex was the next day approved it. That's not a great way to do it, but it worked for the after medicine, and they get it through enough Vertex prescription systems. And then the other one was kind of the same way. It's like we went through every step, and they're like, no, we're not going to cover it. We're not going to cover it. And finally, Vertex stepped into and was able to help out. But it is. I kind of have to coach parents on what to say and what not to say.
Yeah.
Don't say, okay, I guess I can use some of my savings to try to pay for this. Don't tell them that.
Yeah.
Because it's maybe not the exact right way to do it, but I definitely talk to parents first before they talk to anybody.
Yeah. Yeah, because so often those third parties won't speak to us or to care teams. They only want to talk to the family. Yes. Yeah. 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 And no situation ever has the exact same outcome. Like every maximizer alternate funding case ends like slightly differently. So there's no formula of like, here's what we're going to do for this. Yeah.
So just so everyone knows, each one of these panelists did create a handout, and the handout is available if you go to the actual app. There is a tab there, so make sure to go to that and reference it so it can serve as a tool when you return. I just want to thank all the speakers today for coming and presenting. Your information is so valuable, and it's really important for our community to know how to help. I wish Hannah Fan's literature library was somewhere on mycff.org, because I know that all of us could use a Hannah Fan and a Kyle at their clinic. So we'll have to put a plug and ask someone at the CF clinical team to see if they can add that. Also, just wanted to let you guys know to keep all of your requests after this session into your feedback to the NACFC Program Planning Committee. We'd like to bring this back. This session is under the Health Equity and Access to Care Committee that exists within the Program Planning Committee. So we ask that you continue to put what your needs are as it relates to access to care, so we can bring these types of conversations to the conference, especially on a Wednesday where anyone can attend, and one that is of value that you could take something back to apply to your day-to-day. So thank you guys for attending today on a Wednesday, and enjoy the rest of your time here.